my name is Tina Vילsbol. I'm a professor at University of Copenhagen in Denmark, where I also see patients. It's a pleasure to be here today, and my presentation from now on will focus very much indeed on GLP-1, but with a specific focus on semaglutide. Semaglutide is a new GLP-1 receptor agonist. It's also an analog, and it is a very interesting peptide. I'm sure you know that the native GLP-1 has a half-life of only a few minutes. What you see on this slide here is the native peptide and the composition of the amino acids. When we are looking into semaglutide, there are very, very high homology with the native peptide, actually as high as 94%. But you can see the differences marked here. 3 different amino acid substitutions have been conducted, and then there is a fatty acid chain which has been attached to the peptide, which these rather small changes dramatically change the pharmacokinetic profile of GLP-1, going from a half-life of minutes up to a half-life of 1 week, making it suitable as a once-weekly injection. Semaglutide has been evaluated in many, many patients. Actually today, and it has been evaluated in more than 14,000 patients for up to 2 years of treatment. In this presentation, I will focus specifically on 5 trials in the beginning. That is the backbone trials of semaglutide, trials where it has been evaluated in patients treated with nothing but only diet, monotherapy, in combination with other glucose-lowering drugs taken orally, and also in combination with insulin. Then I will focus on SUSTAIN-6, which is the cardiovascular outcome trial, and finally I will give you an overview of how does semaglutide or Ozempic compare to a currently available GLP-1 receptor agonist, which is dulaglutide or Trulicity, that has been evaluated indeed in the SUSTAIN-7. When treating our patients with Ozempic, and also in the phase 3 program, which I'm referring to today, 2 different doses are in general the recommended doses. You start with low dose in both situations, 0.25 milligram. I'll come back to how we do it in real practice, but you start with 0.25 milligrams every week for a month. Then you titrate the patient to 0.5 milligram for at least either the rest of the time or for another period of a month. And then if you want to target up to 1 milligram of semaglutide, you then do that forward on. So it is actually 3 different pens. It is, as we know with GLP-1 receptor agonist, a matter of titrating slowly in order for the patients to adapt to the GLP-1 analog in order for them not to get too many side effects. In general, I've now had semaglutide on the market close to a year, and it really works well to titrate them slow. In some situations, you might need a little bit longer than the 1 month, but in general, it is really clinical possible to push the patient up to either 0.5 or 1 milligram. From the SUSTAIN program or the phase 3 program with semaglutide, I'll start on focusing on what we as diabetologists have been focusing on very much indeed recent years, Hba1c reduction. And to my opinion, semaglutide is the most potent, of course beyond insulin, glucose-lowering drug that we see. Insulin is really good, but we know that you can go as low as you want and even into hypoglycemia. I'll now focus on the data from the SUSTAIN program in respect to Hba1c reduction. On this slide you can see, and I'm sure you agree with me, that both doses of semaglutide, 0.5 milligram and 1 milligram, are really efficacious. They do induce clinical relevant, sustained effects on Hba1c reduction in the average of 1.2% up to 1.8%, depending on the patient and depending on the dose, but very clinical relevant. Here you can see compared to drugs that you know, Januvia in the SUSTAIN-2, it's much more efficacious. It's also more efficacious as Bydureon in the SUSTAIN-3. But in general, very clinical relevant reductions. And they are so relevant that when the EASD or the ADA position statement or the consensus report was Published last year at the ESD in October. The publications are in Diabetologica and Diabetes Care. Semaglutide is actually the compound being, judged to be the greatest glucose-lowering compound seen currently on the market. What is very important in respect to treating patients with type 2 diabetes today, and what is really interesting in the new consensus reports is, I'm actually a big fan of these reports because they're very progressive, they're very updated, they're very evidence-based, and they really challenge us as clinicians because we have to consider every time we sit in front of a patient, and I really mean it, every time you sit in front of a patient, you have to judge, well, does this patient have established cardiovascular disease? Then it is straightforward. Then we should really consider SGLT2 or GLP-1. Or am I actually worried about this patient, whether it has cardiovascular disease? Then it is a demand that I elucidate whether they have it or not. That is why it is very central in the new consensus reports. So when choosing glucose-lowering medication and reading the consensus report, we have to, when we sit in front of the patient, to consider, does this patient have atherosclerotic cardiovascular disease? If that predominates, well, we have two choices, either a GLP-1 receptor agonist or an SGLT2 inhibitor. I will here focus on the GLP-1 receptor agonist, and it is actually so dominant that it has also been incorporated in the ACC expert consensus decision. GLP-1 receptor agonists also have a dominant effect or a dominant place in the treatment algorithm in the ACC expert consensus decision. So it is there. It has actually taken a while, to my opinion. I've been working within the field of GLP-1 for 20 years. That's of course why I'm happy with this, but it has a very central place if our patient have cardiovascular disease. I'll focus now a little bit on SUSTAIN 6, which is a pre-approval trial conducted with semaglutide, actually published back some years ago, but it's a trial including 3,300 patients, even before semaglutide was on the market, comparing the two different clinical relevant doses of semaglutide or Ozempic, 1 milligram or 0.5 milligram compared to placebo. It's a trial that was conducted for 2 years, and during the 2 years, patients who had events in respect to cardiovascular death, myocardial infarction, and stroke were evaluated in the trial. Patients were initiated, as I showed you before, 0.25, 0.5, and up to 1 milligram if they were randomized to that. The primary outcome of the SUSTAIN, I must say, I was part of the group. I'm the last author on the New England Journal paper on the SUSTAIN 6. And I was really, really surprised, but also very happy for our patients to see the primary outcome from the trial. Here you see the event rate 8.9 in the placebo group and 6.6 in the patient receiving semaglutide. A 26% reduction in the risk in the patients. A hazard ratio of 0.72. Significant for non-inferiority, but also significant for superiority. Very important data for our patients. We discussed why that is. One of the contributing factors could actually be, at least to some extent, body weight. It's not the only one, but I really see semaglutide as a very potent drug in respect to decreasing our weight in our patients. And that was also what they saw when they wrote the consensus report published last year. And here you can see semaglutide is actually the compound evaluated as the most efficacious in respect to body weight reduction. And I will show you data on the next couple of slides why that is. Because if you compare semaglutide with the current available GLP-1 receptor agonist or GLP-1 analog dulaglutide, the clinical relevant doses of Trulicity compared to Ozempic, in this trial, the SUSTAIN 6, a 40-week trial comparing these four arms. Well, data you see here. Here you see the effect. Ozempic demonstrated superior, and it's with capital letter because it was very superior. 1.8% reduction in Hba1c with semaglutide 1 milligram compared to 1.4% reduction with Trulicity 1.5 milligram. also the two low doses, significant effect in favor of Ozempic versus Trulicity. Very nice result. And what I like on this is the flat curve at the last part of this slide here, as you see in Hba1c. Usually, when you have such a significant effect on Hba1c reduction, it is correlated with a body weight increase, but with Ozempic, you actually, in this situation, 40 weeks, you see 6.5 kilo body weight reduction, which is actually more than twice as much as you see with the maximum dose of Trulicity. And here, look at the figure. There's not a plateau yet. It is actually still going down. And I've had Ozempic on the market now for almost a year, and the patient come back and they're really, really happy about this body weight decrease. If you look into how much the effect is in respect to 5% body weight decrease or more than 10% body weight decrease, please focus on the right part of this slide. 27% of the patients, it's actually almost 1/3 of the patient have a body weight decrease of more than 10%, meaning that it's more than it's almost 1 out of 3 that lose more than 9 kilos when they receive treatment with Ozempic, and at the same time they have a significant effect on Hba1c. With Ozempic, we have the 3 different doses. Start dose is 0.25, then you can step up to 0.5 milligram, and you can decide whether you want to push the patient up to 1 milligram. It's 3 different pens. In the beginning, you have to get used to it, but you get used to it very easily, and the patient, they just have to know it from the beginning. To summarize my presentation before I let you go, Ozempic is a new once-weekly GLP-1 receptor agonist. It is really suitable as a once-weekly injection. It has an average reduction in Hba1c up to approximately 1.8%, an average weight reduction of up to 6.5 kilos. Of course, there are patients that lose less, but there are certainly also patients that lose more. I said 27% lose more than 10%, and then it has, as judged by the SUSTAIN 6, a 26% risk reduction in MACE versus placebo. That was all. Good luck with prescribing Ozempic to your patients with type 2 diabetes. Thank you very much for your attention.